This is I believe our 23rd webinar. My name is Al Stammers, and my co-moderator this evening is Ed Harmon. And we're very excited about today's topic. In the 23 webinars we've had before, we haven't had a pro-con. So I really want to thank our presenters, Chelsea and Alex, who we'll introduce in just a second, for taking this on. And it's a very timely topic. I love going to meetings and listening to the pediatric perfusionists debate this back and forth. And we're looking forward to both of their presentations. A couple of housekeeping details. Remember to get your 1.2 Category 1 credits. Please stay on as long as possible. I don't think we have to remind you that. This will be stimulating right through the end in the Q&A session. The post-survey, that's a very short survey that you need to do. The CEU certificate is emailed, usually within a week's time. And then, of course, we post all of these presentations on YouTube. Well, every one of them is on YouTube right now. On the left-hand side of your screen, if you're seeing this, you can see the questions for your survey to receive your certificate. And then on the right-hand side, how that will occur. We are going to have a discussion session. It usually lasts the last 15 or 20 minutes. I'm sure it's going to be very lively today, so looking forward to it. Remember, in the Zoom conference area, you've got that ability to go ahead. When you do submit a question, others can like it and vote on it. And as that happens, it gets moved to the top of the screen, the queue. So both Ed and myself will see that, and then we'll choose from those as we move down the list. So please participate. We'd love to have the Q&A session very lively, as I'm sure it will be. I'm going to begin by introducing Chelsea, and then Ed will introduce Alex. So it is my pleasure to introduce Chelsea Capone. She and I are both alumni of the same program in New York and Syracuse. And so it's great to have her here as a fellow graduate of SUNY. Chelsea's got a great background, a huge amount of experience in pediatrics. She's worked at a number of hospitals, both on the West Coast, on the East Coast, including UCSF, Bonhoeffer Children's Hospital in San Francisco, and then at Stanford as well as Children's Hospital of Philadelphia, and now is the chief perfusionist at the Medical College of Georgia at Children's Hospital in Georgia, and she works with Dr. St. Louis down there. Chelsea's also received her certification as an FPP, and she has not only graduated from SUNY, but she also is a medical technologist, went to the SUNY program before she went to perfusion school. She's had multiple presentations over the last decade at multiple venues, including both AMSEC and also local meetings, both in Pennsylvania and throughout the East Coast. And with that, I welcome Chelsea, and Chelsea is going to take the con of the argument right now. But before we begin with that, I'm going to turn over to Ed. And Ed, if you'd be so kind as to introduce Alex.
Hi, so I'm here to introduce Alex Hank. She is fairly new to the perfusion game in the last couple of years. She graduated from Medical University of South Carolina back just in May 2020 as COVID started raging. Crazy time to go into the workforce. She started first at Emory, doing everything. It's a busy adult university account that it appears that she has done everything. And then last year came to Children's Hospital of Georgia, where she is now. And she'll be doing the pro side of this discussion today, and we'll turn the time over to them.
Al, can you see my screen? I just want to make sure.
Not yet, Chelsea.
Okay. Hold on. Sorry, everyone.
There we are. We can see it
right.
now, Chelsea.
Beautiful. Thanks, everyone. Sorry about that little technical difficulty. Thank you, Al and Ed, for that wonderful introduction, and welcome, everyone. Thank you for joining us today. We truly appreciate you taking the time out of your busy schedule to participate in this MUF versus non-MUF debate with Alex and I. We have no disclosures. Let's start with the basic principles of ultrafiltration. First developed in the 1970s, the purpose of ultrafiltration is remove plasma water and low molecular weight solutes from the blood while preserving cellular components and plasma proteins. The use of ultrafiltration has been a standard of practice for decades to remove excess fluid with the end goal of increasing hematocrit, platelets, and other plasma proteins. The rate of removal is affected by a multitude of factors, including ultrafiltration coefficient, pore size, surface area, hematocrit, blood flow, negative pressure on the effluent side, and transmembrane pressure. Solutes are either retained or removed according to their size. Any solute less than 65,000 Daltons will be removed depending on the sieving coefficient. Here on the left, a sieving coefficient of 1 is filtered at a rate equal to their concentration, while the right has a sieving coefficient of 0 and remains in the blood and is not filtered at all. These are some of the sieving coefficients for common drugs and electrolytes on bypass. It is important to note that heparin, anesthetic drugs, and electrolytes will be filtered, and this should be closely monitored when using ultrafiltration. There are multiple modalities for ultrafiltration on bypass. Pre-bypass is performed during the priming of the circuit and prior to initiating bypass. It removes excess volume and undesirable components of banked blood products while balancing the prime, thereby allowing us to initiate bypass with a near physiologic prime. Zero balance occurs during bypass and requires the addition of volume to maintain euvolemia. Cuff is the most common form of ultrafiltration and is performed to remove excess volume. This excess volume can come from a fluid overloaded patient, cardioplegia, blood product administration, and crystalloid from the surgical field. And last but not least is MUF. MUF occurs after bypass is terminated, but before protamine. There are a variety of modalities to perform MUF, but all function to increase hematocrit, remove free water, decrease hemodilution, and decrease inflammatory mediators. MUF is performed until circuit contents are completely salvaged, a specific time-based criterion, a hematocrit goal, or a filtrate volume endpoint. I'm now going to turn it over to Alex to review more specifics on MUF.
Thank you, Chelsea. You did a great job explaining the main goals of MUF, so I won't go back over that, but I will get more detailed about the MUF basics. The basics of operating MUF vary from center to center, but most commonly the flow is performed at 10 to 20 mils per kilo, up to 500 mils per. It's performed for at least 10 minutes post-bypass, and I know the 10 minutes feels like an eternity, but it's a good time for team building and joke telling. The patient volume status is monitored very closely during this time, and the volume removed is replaced by the remaining volume in the venous reservoir. By utilizing MUF, we can essentially chase our reservoir with crystalloid to give all of the blood to the patient. Our colleagues at Great Ormond Street first introduced MUF in the 1990s, based off of the need to remove a greater volume of fluid than they had been able to achieve utilizing just normal conventional ultrafiltration. Over time, the improvement of bypass and techniques have resulted in a significant increase in cuff efficiency. And since then, MUF has become a standard practice in the majority of pediatric centers, since pediatric patients are particularly sensitive to the detrimental effects of bypass. Although, as we can all see, there have been many advancements in MUF technology and even techniques since it first originated, it's very important to continuously collaborate with each other and keep up with the ongoing research in order to provide the best possible care to our patients. It's been well researched for decades. This debate that we're going to have isn't going to be groundbreaking, but still, despite all of this research, a clear answer hasn't really shown its face. So Chelsea and I are simply here to paint both sides of this topic and to further the discussion of the use of MUF during cardiac surgery. So there's two types of MUF. You can either do VA or VV MUF. So just for a quick overview, here is one of the ways, VA, in which it can be performed. I know that it looks pretty complex on the screen, especially if your center is utilizing a manifold, but we'll walk through these pictures together. So on the left side, you can see pretty much a typical bypass circuit. And the only change on the right side is that it's the same circuit, but the cardioplegia line is moved from the aorta and placed onto the venous line. Blood travels retrograde, with reference to bypass, from the arterial cannula, is wide to a separate roller head, goes through the ultrafiltrator and back into the venous line or the right atrium. That arterial line is wide to serve as a volume replacement method when needed. Another kind of MUF would be VV MUF. Some centers choose to utilize this as seen above. And again, we'll walk through this picture together. On the left side, you can see a typical bypass circuit, just like the previous slide. But on the right, this time the blood travels from the IVC to the head, through the filter and back through an IJ venous canal, instead of going to the reservoir as seen during cuff. And again, there's an arterial line Y to serve as a volume replacement method if needed. At the Children's Hospital of Georgia, for patients under 10 kilos, Chelsea and I, yes, Chelsea, the person debating the con side of this presentation, utilize this setup. The majority of our patients under 50 kilograms, we do MUF on. Thankfully, we have a very patient and kind surgeon who understands and supports the advantageous impact that MUF has on our patients. Not biased. Our MUF protocol itself is pretty straightforward. Obviously, it's always tailored to how our patients react to the practice, and both Chelsea and I are very closely monitoring the patient's hemodynamic variables, such as this patient's CVP, blood pressure, safety measures such as our arterial line pressure. Additionally, just in case the con of this debate wants to bring up adverse events, Chelsea has incorporated a safety measure into our circuit by attaching a pressure monitor on the outlet of our circuit to limit the possibility of overpressurizing the MUF. It still can be done, or worse, sucking down negative and risking treatment. So this slide here shows the setup that we use. Full disclosure, we do cuff and MUF. So our ultrafiltrator is already in line, connected to its own roller head. We do not utilize our cardioplegia system at CHOG. So playing devil's advocate here, the downfall of that is that our patients may experience cooling post-bypass. But on the other end, not utilizing our cardioplegia system helps us decrease the chance of accidentally delivering cardioplegia. And we're always prepared to go back on and rearrest if needed. It's important to note that in some centers who do utilize MUF may be significantly, the priming volumes may be greater due to the need to flush out the cardioplegia solution from the MUF line. This can result in a shift that's nearly 100 mils of blood from the venous reservoir to that cardioplegia line, which, as we all know, must be replaced with other volume. So by avoiding our cardioplegia circuit, we only have a prime volume of mils, which is not nearly as large of a shift as centers that use their cardioplegia system. The greater volume that we use in essentially priming the MUF line is essentially pre-treated with our pre-bypass ultrafiltration. We prefer over adding any additional blood or crystalloid before MUF. In addition, just to save every last red blood cell that we can, our MUF line back to our reservoir, but first it stops at a stopcock. And on that stopcock, we have a 60 cc syringe attached so that we can flush the entirety of the filter after MUF is complete for it to go be washed in the cell saver and given back to our patients. You can go next, Chelsea. So MUF, as we all know, has a wide range of benefits, all over the board, increasing the overall hemodynamic status, increasing lengths of stay in the ICU, to our overall coagulation improvements, which is why it's gained such popularity over the years and became a Class 1A recommendation in anesthesia and surgical blood conservation guidelines. But now it's for the fun part. So theory one is that MUF is a safe and established perfusion technique. It has been successfully used in a variety of applications in the perioperative setting to assist in volume reduction and the removal of inflammatory mediators. As we're all pretty much familiar with, the Groom survey was studied in 2011 and showed that 71% of centers use MUF, while 86% use routine ultrafiltration as a whole. So MUF usage has actually steadily increased over the past decade, growing from 42% in 1994 to nearly 75% in 2004. And in 2012, this Groom survey began to include international responses, and the overall trend is about the same in the 2016 data, with a slightly overall higher percentage of non-North American centers using MUF, and primarily between the two types of MUF, majority used AV or VA MUF as opposed to VV, respectively.
Yes, MUF is an established perfusion technique, but is not without its complexities. As observed here, performing MUF requires a more complex circuit. Compared to the simplified circuit on the lower right, the MUF circuit on the left is a much more complex circuit and requires multiple changes to go from bypass to MUF. Increasing the complexity of the bypass circuit increases the chance for human error and circuit disruption. These aren't very well documented, but they do occur. I myself have deprimed the oxygenator. I've caused hypothermia, and I've blown up my MUF circuit more than a few times, so has my colleague here too. So don't let her trick you. Let's move on to the argument that MUF improves hemodilution and decreases edema.
We're all cognizant of the prevalence of hemodilution in cardiac surgery and the negative impact that have on our overall patient morbidity and mortality. To kick this debate off, let's look at Lowe et al. He conducted a strong meta-analysis to summarize and compare the clinical outcomes in adult patients who underwent cardiopulmonary bypass with and without MUF. So in this meta-analysis, all studies were prospective randomized controlled trials. The search began with 6,860 references that pertain to ultrafiltration in cardiac surgery. But after review of each and inclusion, oops, sorry, can you still hear me? Okay, sorry, I thought I got kicked off. But after review of each and the inclusion criteria were met, only 13 studies were included in the final meta-analysis, but that did include over 1,200 patients. So in this meta-analysis, collectively, these studies were in support of MUF, increasing the post-bypass hematocrit. The research is supportive and extensive. To walk you through this chart, the x-axis on each, on the left favors no MUF, whereas the right favors MUF. So as you can see, the post-bypass hematocrit levels were reported by 6 trials, which comprised of a total of 320 patients. The meta-analysis pooled results showed significantly higher post-bypass hematocrit levels in the MUF group versus the non-MUF group. Removing this excessive plasma water not only provided patients with a higher hematocrit, but simultaneously it reduced the overall fluid shift experienced by the patients. Sorry. And these forest plots allow us to appreciate the cumulative effects of the studies. The correlation, moving on to the next one, yep. Grist et al. Recognizes the edema acquired during the perioperative period and researched its contribution to mortality. I wanted to specifically dive into the breakdown of fluid shifts in cardiac surgery. So this chart here is a on pump ins and outs for a specific case. The case is actually a 47-kilo patient who underwent an aortic valve repair and aortoplasty. As you can see, if with me on the right side, the fluid additions on the MUF side included 800 mils of crystalloid, which were added to the circuit to chase the blood being infused to the patient and keep the circuit primed. In addition, they could, capture the blood from the venous line, the cardioplegia heat exchanger, and the hemoconcentrator, which added up to nearly 210 mils total that were drained to the circuit and to the patient. This allowed for all of that whole blood to be returned to the patient, leaving primarily crystalloid in the circuit, so it didn't even have to be processed through the cell saver. Let me remind you, the cell saver removes clotting factors and subsequently is an additional foreign surface contact. So when that comes up in the debate, it's kind of like a pick your poison type of deal. And during the MUF, the hematocrit was increased from 27 to 32%. The fluid balance change at the end of MUF was a mere negative 55 mils, and the patient was allowed to see all of their whole blood return back to them. Before you say that priming the hemoconcentrator right before coming off bypass drops the patient's hematocrit in the long run, I encourage you to consider the idea of flushing your circuit with crystalloid as seen in this study. The research supporting hypervolemia leading to a whole host of problems is well documented, but additionally, it's important to consider that hypovolemia comes with its own host of problems. Like I said, I must have missed that, I'm sorry. I'm not saying that hypovolemia is the way to go. that we need to guide our patients to looking like raisins when they go to the ICU. Surely we've all heard that from the ICU members that our patients come back fluffy, which although that's not always worded appropriately, it does have its purpose, and that they know what goes on post-operatively and the fluid shifts that are necessary post-bypass, the addition of drugs, more blood products. But rather than thinking of ultrafiltration as a more basis, consider it as giving our patients the best form of normal volemia as possible. I'm not saying ultrafiltration is end all be all, but in that we need to run our circuits to the level detector or excessively muff at the end of a case, I recognize the importance of balance on this topic. Like I said before, the goal isn't to send our patients looking like raisins. The goal here is to utilize ultrafiltration to keep more control over our patient volume status so that if, and most likely when needed, we can implement it quickly to correct this stray away from normal volemia. Just to hit you on the other side of hypovolemia, this research studied the idea of excessive ultrafiltration being a contributor to AKI and eventual fluid retention. And in this research, from the short summary, you can see that the organ dysfunction that was listed on the previous graph due to hypovolemia can actually be mitigated if our cuff and muff volumes stay under the recommended 119.9 mils per kilo as researched in this study. I want to stress the importance to find that solid balance throughout surgery and give our patients the best possible chance to have an uneventful operation.
As we are all aware, AKI is independently associated with increased mortality, prolonged mechanical ventilation, longer ICU and hospital lengths of stay, increased resource utilization, and overall healthcare costs. Therefore, our job as perfusionists is to minimize the risk of AKI. And I know everyone's thinking, MUF is utilized to reduce hemodilution edema and therefore AKI. However, this 2021 article that Alex just spoke about reviewed 532 patients less than a year of age and identified a potentially new risk factor for AKI, and that's excessive ultrafiltration volume. The authors hypothesized that excessive ultrafiltration may result in hypovolemia and limited renal blood flow leading to AKI. Patients with the highest risk of developing AKI are those requiring complex surgical interventions in combination with high total ultrafiltration volumes. 12% of patients in the cohort developed post-op AKI. A higher index total ultrafiltration volume was associated with increased risk of AKI. Patients with AKI took longer to reach net negative fluid balance at 3 days versus 2, even when extensive ultrafiltration happened during bypass. Although more complex surgeries carry the risk of developing AKI, this risk was reduced when ultrafiltration volumes were below 119.9 mils per kilo. Both graphs here show the total ultrafiltration is effective at reducing peak cumulative fluid overload up to 119.9 mils per kilo. But as ultrafiltration volume exceeds that, the benefit diminishes. This study concluded that ultrafiltration volume of 119.9 mils per kilo represents a therapeutic target that minimized post-bypass AKI and fluid overload risk, while achieving the benefits commonly associated with ultrafiltration. Ultrafiltration beyond this point does not prevent fluid overload in this cohort and may needlessly increase the risk of AKI. So I argue, is MUF necessary when cuff can adequately remove this amount of fluid? Also, when using MUF, are we overfiltering patients, causing increased risk of AKI? The next argument is that MUF decreases inflammatory mediators.
So the systemic inflammatory response that occurs in patients after bypass remains a major cause of morbidity and mortality. The most evident part of the whole body inflammatory response is the systemic endothelial cell neutrophil adhesion that results from the release of complement degradation products and cytokines after blood exposure to artificial surfaces. Additional activation of this complement system are things such as shear stress, anemia, hypothermia, many of the things that we do on bypass activate our complement system. In addition to this, many of the markers of inflammation, such as interleukin 6 and 8, are simultaneously responsible for direct cell damage. It's important to limit these when we can. So full disclosure, this is a chart on TAVR patients and the impact that SEERS has on overall mortality. Although these patients didn't end up seeing a bypass circuit, you can take from this chart the severity of SEERS if patients develop it. This chart excluded the sickest of the 6 patients and showed a follow-up for 1 year, which those who developed SEERS saw nearly a 20% greater mortality rate than those who didn't. Additionally, those that experienced SEERS saw a major increase in the inflammatory mediators, interleukin 6 and 8. I want you to remember these 2 inflammatory mediators as we move on to the next slides. So these charts reiterate the increase in each inflammatory mediator and their presence in SEERS. There are multiple that bypass triggers that has a great impact on the development of SEERS. There's a variety of advancements that have been made to dampen this inflammatory response. I know some of you are probably thinking, can we avoid ultrafiltration? And the answer is sure, we can try. And we've attempted to with pharmacological agents to make smaller circuits, coated circuits, trying to stay off pump. But the reality is that a perfect circuit isn't very reasonable. So how can we further decrease of SEERS and hemodilution that we previously spoke about all at the same time? MUF has been researched to reduce the serum level of inflammatory mediators generated by bypass and to improve myocardial postoperative function. So in this study by Wang, you can go to the next slide, Chelsea. Most of the inflammatory mediators have a molecular weight that is below the molecular pore size of commonly used ultrafiltrators, which should allow them to float freely through the effluent line of your filtrator. This study demonstrates that the ultrafiltration is a strategy that can be used during bypass in the adult population. As you can see, post-ultrafiltration, the interleukin removal rate was much in the ultrafiltrated group versus the control group. And moving on further, with Grunenfelder et al., researched the presence of interleukin 6 in the effluent volume of MUF. And in this study, you could go to the next one, interleukin 6 decreased by nearly 60%. Although the levels did not show, or the levels showed to level out around 48 hours post-surgery, the cytokine was seen to be drastically higher during arguably one of the most critical times for a patient postoperatively, immediately after bypass, the first 24 hours. Decreasing this interleukin 6 can help reduce adverse events, reduce mortality, and increase overall surgical outcomes. And last but certainly not least, to show some additional research that supports all of this. It isn't just interleukin 6 and 8. There's a variety of inflammatory mediators that have been seen to cause SEERS that can be removed via MUF. And one of the things that we've always learned in school was that MUF reduced inflammatory mediators. We're taught that because research supports that. A PubMed search that was done in 2013 and published in 2014, but they date all the way back to 1987. The majority say that ultrafiltration reduces circulating inflammatory mediators, overall increases cardiovascular performance, and has great effects on pulmonary function, total body water, coagulation, blood product usage, and overall safety.
This study by Tassani et al. Shows that fibrinolytic markers, aka SEERS response indicators, were only slightly diminished by ultrafiltration and for a very limited time post-bypass, immediately post-bypass. And even though the markers were lower in the ultrafiltration group, it's important to note that outcomes were not different between the two groups. This study shows that when measuring platelet counts and PF4 levels, there's also no difference between MUF, CUF, and control groups. Once again, the effectiveness of MUF, when speaking in terms of decreasing inflammatory markers, are limited to the only first 24 hours post-bypass. Inflammatory mediators significantly increased after bypass in both groups, with no differences seen at the 24-hour mark. In addition, there was no statistically significant difference in blood product usage as seen on the right. Chu et al. Demonstrated that MUF does not significantly decrease levels of inflammatory markers as observed here. Although the MUF group showed improvement in the post-op oxygenation, a decrease in drainage, and improved hemodynamics, there's no detectable differences for inflammatory markers between the MUF and non-MUF group. In addition, coagulation and hemodynamic endpoints such as mean BP, need for transfusion, and chest tube output did not differ. The authors found that their results do not support the argument that MUF improves post-op organ function by modulation of markers of inflammation. The authors theorized that the patient improves during MUF are due to the removal of plasma water, not inflammatory mediators. If this is the case, why don't we just ultrafiltrate more aggressively during bypass to get such benefits? Finally, this article by Ming et al. Found that TNF and IL-8 increased and E-selectin did not change during the MUF period. Yes, it increased. The authors theorized that as they performed MUF, the hemodynamics improved, so they subsequently increased the MUF flow. However, these mediators did increase, mainly due to the increased contact with foreign surfaces during the MUF period. In addition to these findings, there was no statistically significant difference in chest tube output, days on the ventilator, or ICU length of stay between the groups. Now for the argument that MUF decreases blood loss and transfusion. The theory is that MUF increases hematocrit, platelets, and plasma proteins, thereby decreasing transfusion needs and complications associated with blood transfusions. But let's see what Alex has to say about this.
Going back to the meta-analysis that I spoke about before, it's pretty much all-encompassing and has all of our research summarized in one spot. So I chose to pull their graph from their chest tube drainage as well. It's a little bit different from the previous one in that those that favor MUF are now on the left, and those that favor no MUF are on the right. And as you can see, the post-operative chest tube drainage amount was reported by 10 studies. That includes a total of 1,146 patients. So a large study group. And the combined meta-analysis revealed a significantly lower level of chest tube drainage in the MUF group versus the no MUF group, and that reached significance. The mean difference was nearly 105 mils. Again, there's an abundance of research out there supporting this, and just moving on to the next one in terms of blood transfusion. The blood transfusion rate was available in 9 of the included studies, a total of 1,056 patients. There was a significantly lower blood transfusion rate in the MUF group on the meta-analysis, a mean difference of 0.73 units. That's nearly an entire unit that an exposure could have been avoided. And before you say that you need to add blood to prime the MUF circuit, I challenge you to think longer term than that. Once you use that patient volume to prime the filtrator, although you may be riding lower when weaning from bypass, your patient will see that blood back by the end of MUF. And it will be more well-rounded blood if you think about it, a higher hematocrit, less inflammatory mediators. And additionally, many centers cuff and MUF, so this ultrafiltrator will already be primed out and can be given back to the patient all the way up until crystalloid flushed. Banjo et al. Conducted a prospective randomized study that aimed at pinpointing the best candidates for MUF during congenital heart operations. And in this study, the requirements for red blood cell and coagulation factors were significantly lower in the MUF patients compared to the controls. And that follows across the board overall for even those that included pre-op pulmonary hypertension, neonates, prolonged bypass runs. And looking even further into this, additionally, those in both moderate and deep hypothermic cases, MUF significantly reduced the requirement for blood transfusion. Further research is definitely needed to strengthen the research behind these populations and to better tailor the utilization of MUF to certain patient populations, such as those, differing complex surgeries, moderate to deep hypothermia, smaller patients in reference to circuit size. The list goes on and on.
This 2012 article from our own hospital, the Children's Hospital of Georgia, shows that simplifying and miniaturizing circuits is a main blood conservation technique leading to significant benefits for our patients, including fewer ventilator days, lower ionotropic support, and shorter length of stay. Blood conservation should be maximized, not just for negative side effects, but also for cost and resource allocation. It was also observed that ionotropic support, ventilator days, and length of stay all significantly decreased in the blood conservation group, despite having lower intraop hematocrit levels, longer bypass, and cross-clamp time. We can all agree that less transfusions equal less complications. Here on the top, we see the biventricular repairs, and on the bottom, the univentricular repairs. All patients benefited from circuit minimization. Needless to say, advances in techniques and technology has reduced the need to utilize MUF. Additional transfusions can confer extra risks, including immune and inflammatory reactions, pulmonary complications, prolonged length of stay, mechanical ventilation, infection, and extra resources and costs. Why do this when there are other methods to increase hematocrit without addition of donor blood? For example, on the top left, there is a significant reduction in the frequency of donor blood transfusion in the first 6 hours post-op when using cell savers. And the left middle and left bottom support this as well. On the right top, we see that this study concluded that the reduction in the administration of blood products and lower post-op blood losses associated with the use of ANH in pediatric cardiac surgery patients, not MUF. And on the bottom right, blood conservation techniques such as ANH, RAP, and VAP do not cause statistically significant declines in cerebral saturations, an event that can occur during MUF. Therefore, I argue, we must employ a variety of blood conservation strategies, not just rely on one alone, which would be MUF. MUF is a singular standalone answer for blood conservation. If we use a combination of the techniques listed here and use a multidisciplinary, multimodal approach, it makes the need for MUF obsolete. This study demonstrates that TEG parameters worsen during MUF, and the more volume that is removed increases the severity of the impact. However, the parameters improved once protamine was administered. The authors theorized that MUF increases the concentration of heparin, leading to worse TEG parameters and bleeding. But we all know how detrimental this bleeding can be to the efficacy of MUF while MUF is being performed. And also delaying protamine can lead to patients needing additional transfusions. And our final section is that MUF improves cardiac and pulmonary function, improves outcomes, and decreases length of stay.
Back to that meta-analysis. Why stray away from something this good? The post-operative duration of ICU stay was actually reported in 6 of the studies, which included a total of 916 patients. So again, a large sample size. In all of those studies reported a numerical trend towards shorter duration of ICU stay in the MUF group. Although that didn't reach statistical significance, it's important to note that MUF did not correlate with longer ICU stays. So although these are pretty much dead set near the middle, it's not harmful. So the debate between if it's helpful or harmful is kind of answered in this meta-analysis.
And this study, conducted by Williams et al., determined that when a standardized volume of fluid is removed during bypass, the hematocrit, hemodynamics, ventricular function, and requirement for blood products and post-op resources did not differ between patients receiving conventional ultrafiltration and MUF. As for pulmonary function improving from MUF, this study shows that lung compliance and gas exchange capacity is decreased in both groups equally, as observed here. Overall, both groups had no statistically significant difference in static pulmonary compliance upon admission to the ICU or 6 hours later. Also, on the left, the graph shows that MUF has a median improvement on static and dynamic lung compliance as well as gas exchange capacity, but is not sustained to the ICU or 6 hours later again. Also, there is no significant difference in ionotropic support, duration of intubation, or length of ICU or hospital stay. The authors concluded that when MUF is employed in patients between 5 and 10 kilos, the ones that usually need it most, there's immediate improvement in pulmonary dysfunction post-MUF, but this is not sustained. This study actually supports Alex's argument that MUF decreases post-op blood loss reflected in chest tube drainage and RBC transfusion because it was less in the MUF group. But there's a big but. There were no differences in hemodynamic, oxygen support, and pulmonary function at these same marks. And the removal of inflammatory mediators with any type of ultrafiltration does not necessarily reduce all inflammation for patients on bypass.
So in conclusion, MUF is still widely used. It's used by nearly 75% of centers. The evidence to support it is extensive. It's a great option for volume reduction and inflammatory mediator removal during cardiac surgery. I see Chelsea's point But at the same time, you don't use a hammer to put a screw in. There are many tools in our toolbox that we can take advantage of to tackle hemodilution on bypass. And while I see Chelsea's side of the debate, miniature circuits, limiting hemodilution, planning ahead, the rising concern for adverse events, we're all well aware that if you want to find a study that demonstrates that MUF doesn't work, you can probably find it. But I do believe that moving forward as clinicians, it is important to hone in on our differing patient populations and the types of surgeries that we are performing to determine if MUF is beneficial for them, such as our smaller patients, longer bypass runs, deep hypothermia patients. If the answer is yes, then how much? That is a loaded million-dollar question. But instead of crossing MUF off the drawing board completely, how can we utilize it more judiciously to better serve our patients that can benefit from it? There are many times when you can't do anything about a surgeon dropping excessive clear volume in your reservoir, or heparinizing early and you're not able to do ANH or wrap, or your patient comes into the OR with a hematocrit of 26. However, we have a tool in ultrafiltration that we can prescriptively use as needed. It is essential that as clinicians, regardless of which side of the MUF debate you support, that you lean into each other and share your experiences and perspectives. Thank you guys for hearing my side of this debate, and I kindly ask that you wait until the end of the session to ask more questions. Chelsea's going to also give a conclusion.
And of course, my argument is that MUF is no longer relevant, and I've presented a multitude of studies that question its efficacy. Why make our lives harder with a technique that increases complexity and complications while not conferring any or even significant benefits to our patients? Speaking of complications of MUF, the list is extensive. Once again, rarely described in literature, but can be significant. Increased complexity in our circuit can lead to human errors, especially in the post-bypass phase of surgery, which is already a critical phase of the surgery. Like Alex said, you can have patient cooling along with everything else here listed on the screen. By eliminating MUF and relying solely on conventional ultrafiltration, we can simplify and miniaturize the circuit, reduce hemodilution and transfusions, improve safety, and shorten our OR time by at least 10 to 15 minutes. MUF is an established perfusion technique, but is not without its complexities. As observed here, once again, it is a more complex circuit. Why would you choose to have that mess on the right or the middle when you could have that beautiful circuit, or sorry, that mess on the left or in the middle, when you could have that simple, beautiful circuit on the right? One of my favorite articles that supports my argument is by McRobb et al. It is a retrospective study released in 2017 exploring the benefits of discontinuing MUF. They decided to discontinue MUF in order to create simplified and miniaturized circuit, leading to reduction in hemodilution and improved safety. They hypothesized that preventing hemodilution by circuit minimization and simplification was more advantageous than using a more complicated higher prime circuit and reversing hemodilution via MUF. The authors explained that at least 100 mLs is necessary to prime their MUF circuit, which is through the cardioplegia. This leads to decreased hematocrit if crystalloid is added, or transfusion of red blood cells immediately before weaning from bypass. In addition, they were able to more aggressively ultrafiltrate during bypass as they didn't need the additional volume to prime the MUF circuit. If they didn't use MUF, when they didn't use MUF, they were able to deprime their filter for additional volume while weaning. They found that this simplified non-MUF circuit, in combination with less tubing, a smaller ultrafiltration device, and not priming the cardioplegia circuit for MUF, they had 150 mLs of a fluid shift. That's a lot of fluid when we have these neonates on bypass. And observed here, both neonatal and pediatric cohorts required less blood in the non-MUF group than the MUF. In addition, they were able to wean from bypass with a hematocrit greater than 40% in non-MUF group, resulting in improved hemodynamics, including lower CVP, higher blood pressure, and lower ionotropic support. They also observed that less volume was needed to fill the patient compared to weaning those with the lower hematocrit MUF group. Being able to wean with a lower CVP further enhances the volume benefit. The improvement we commonly seen during MUF in hemodynamics isn't due to reducing inflammatory mediators or sudden decrease in myocardial edema, but more likely to an increase in hematocrit and blood viscosity, because before MUF, you are weaning at a lower hematocrit and immediately increasing that hematocrit during MUF. It's also important to note that trying to rapidly take off volume during MUF can lead to hypotension, higher ionotropic requirements, and reinstituting bypass for hemodynamic instability, which we all know is a pain when you flush blood through your cardioplegia circuit. And once again, safety problems can occur. The authors go on to show that MUF results in more hemodilution and potentially more edema compared to the non-MUF group. And MUF receives more intra-op blood products, surprisingly. The MUF group received a greater volume of RBCs in the intra and peri-op periods. They're also more likely to be exposed to a second donor unit. The neonatal MUF group had a significantly higher rate of second RBC donor exposure, but had a lower last bypass hematocrit and no difference in the post-MUF and ICU hematocrits compared to the non-MUF group. These graphs also show that non-MUF patients have significantly higher significantly higher last bypass hematocrit and same ICU hematocrit, despite receiving less RBCs. This advantage is due to circuit minimization by eliminating MUF. Finally, these show eliminating MUF doesn't have any negative impact on outcomes, and there's no difference between the groups. Why would anyone choose to have the situation on the right when they could have the situation on the left coming off bypass? And now other studies are starting to trickle out that support McRob's argument that a simple low prime circuit is preferable to MUF based on the fact that it simplifies the circuit, reduces prime volume, and decreases transfusion. As McRob aptly states, prevention of hemodilution via circuit minimization is better than reversing hemodilution versus MUF. So he concludes that by removing MUF, they're able to have a simpler circuit, decrease transfusions, enhance safety, reduce hemodilution, as well as many other benefits, including the ones listed here. In conclusion, I still argue that MUF is not necessary. It confers a multitude of risks and it has limited benefits with certain patient populations. My question to everyone is why use MUF? Why, when we have alternatives available that provide the same, if not better care to our patients and are safer to use? Why rest on our laurels and use MUF to treat hemodilution when we could prevent said hemodilution in the first place? We need to be proactive, not reactive. Thank you.
Excellent, Chelsea and Alex. Thank you so much. And if you would be so kind as thank you, dear. Well, this is great. And I can't think of anything that is more intriguing to the perfusionist mind in the sense that we really hold on to our ultrafiltrators very tightly, or we don't believe in them. It's something that there's just this polarization within perfusion today. And I appreciate you both trying to help us with understand the science with great summarizations on both sides. We have quite a few questions. So if you don't mind, as these questions are being asked, if you guys can keep your answers relatively short so we can get to as many of them as possible. I'm going to start, and we'll start with Chelsea and then Alex, but just brief answers. What happens to NIRS values as you're muffing using a VA or an AV technique, assuming it's on cerebral monitoring?
So we monitor those very closely, and as we increase our MUF flow, if we see those NIRS values go down, our surgeon will discontinue MUF, which, I mean, that's a huge problem, because if you're only 2 minutes into MUF and you think you're going to get to a certain hematocrit and you can't because the NIRS values, you end up having a much lower hematocrit than you planned.
Okay, question?
Sorry, you cut in and out. Did you say something towards me?
I was saying Ed would
Oh,
ask, we're just going back and forth if that's okay, but
Absolutely.
I've got quite a few.
So this is a question that I'm gonna, I think pushing this button will do something. answering live. Oh, it doesn't tell me anything, but Anton John Burnett asked a question, which I agree with. This is more for Alex. You know, if MUF is so great, then why aren't we doing it for older kids or adults, you know, especially with ones that have renal issues or ones that you know you're going to have to transfuse again. You know, you were stating, you know, you do it up to 50 kilos. We do similar at my institution. Why don't you do it for bigger kids?
Thanks, Anton, for asking that question. People are doing it for larger kids. I know it's just worded differently. I know at Duke, they do a thing called a long lining, which is essentially MUF after bypass, a line that just goes right back to anesthesia. So we are doing it for larger people. And to be honest, similar effects are seen. It was even taken back to Emory with Dr. Mani Danishman. So as for in terms of your renal impairment, I just gave this presentation similarly, but on adults at the Carolina Symposium. But in one of the research studies, the postoperative pre and post MUF creatinine clearance were very similar in both of the groups, which indicated really no change in that renal function as a result of the use of ultrafiltration. And at the same time, kind of piggybacking off of the research that Chelsea and I both spoke about, there's a limit on how much you can ultrafiltrate before you start to see that AKI or exasperated kidney disease. So that's what I guess I challenge that it is an adult world. It's just not seen as popularly.
Thanks, Alex.
Great,
Thanks,
thank
Ed. Let me ask Chelsea a question. Chelsea, if you read the MSAC standards and guidelines for pediatric practice, which are several years old now, Standard 16 does state as a guideline that the use of MUF should be utilized to optimize hemodynamics and hematocrit. So how do you argue against a clinical practice guideline as opposed to a standard? It's not saying shall, it said should, but how do you address that?
Well, my only argument is I've worked at institutions that use MUF and don't use MUF. And so when we haven't used MUF, it's similar to McRob's findings where we come off with a higher hematocrit and the patients have more hemodynamic stability. So they're already flying off bypass and they don't need the MUF. I find that when I MUF, especially if I'm on a certain level with the hematocrit and we start to MUF, the patients struggle more. So I default to coming off with a guaranteed hematocrit. I would much rather come off with a hematocrit of 40 and know I'm at 40 than come off with a hematocrit of 30 and hope that MUF works, that we don't have any complications. And I have seen that I'm able to ultrafilter more when I'm on bypass because I know I don't need that extra volume while I'm muffing. So it's only a clinical observation. I don't really have much more than that.
Thank you, Chelsea. Ed?
I'm going to read a question from Peter Damiani. Sorry if I'm butchering your name. Any thoughts on using CVVH in the unit compared to MUF or cuff? Not sure exactly what they're asking, but.
Well, I mean, if the patient's on ECMO, I completely support it. I can't see using CVVH. Like if there's no other support, if they're not on ECMO to put in a CVVH line, maybe he can explain a little bit better so we can have a better answer.
Well, let me go ahead. There's another question in regards to to continual renal replacement therapy. But I want to jump to Umpajan Thera's question. And would you use MUF in an individual who had chronic kidney disease? Somebody was oliguric or anuric. And I'll address that to Alex.
Yeah, so I tried to piggyback that question with the other adult question that I received. But in research that I saw in his presentation last weekend was that creatinine clearance was actually pretty similar across both groups. So research is definitely needed to fine tune if that exasperates kidney disease further. But the Kuntz et al. Study that I was looking at showed similar creatinine clearance across both groups.
And just, sorry if I can follow up. So those groups, and I apologize, Alex, if I missed this, one of them was in failure, renal failure, and one was not?
I have to go back and double check. I don't have that one pulled up because mine
That's
was
okay.
primarily
That's okay.
pediatric, but I'll look into it and get back to you.
Yeah, I would think the one in renal failure, you're going to have a very high
I think
level.
that it was, let me find it and I'll get back to you and send it your way.
Sure, no problem. Thank you. Ed?
Chelsea, one of your arguments was using mini circuits instead of priming a MUF circuit. In my program, I know all MUF circuits are a little bit different, but would that mean you wouldn't use any cuff? You wouldn't use an ultrafilter at all? Because in most circuits I've seen, there's not much difference in volume from the MUF circuit to just a traditional cuff circuit.
I'm always in support of ultrafiltration on bypass, and I think it's necessary for most of our pediatric patients. And it's great. What Alex showed you, the MUF circuit we use here, it minimizes the blood necessary. We really only use 20 mLs. But if you are piggybacking off a cardioplegia circuit, that volume can be much higher. So that's more of what I was speaking to, is that if you have that volume and you're flushing out the cardioplegia circuit, that can be a huge volume shift.
Sure. Okay. Do you use Del Nido at your site?
Yes.
So it's quite a bit of crystalloid and a tiny bit of blood.
Yes, and our surgeon is quite fast. So speaking of ultrafiltering on bypass, it's hard sometimes. I think my bypass run today was 35 minutes, so it doesn't give you a lot of time to take that volume off.
Gotcha. Okay.
But I think it's all depending on your institution, your circuit, your surgeon. I think everyone I'm anti-MUF, but my surgeon wants the MUF, so that's what I do.
Great.
Thank you, Chelsea. And I just want to tell you both, there's loads of questions here. I really apologize for not getting to many of them. And there's also a lot of comments congratulating you both on your presentation. I want to conclude with a question. Bob Bernstein has asked a couple of questions, and this one actually tripped my trigger too. I didn't understand how this could occur. It was a paper, I think, that Chelsea had put up that showed that MUF actually got worse in regards to TEG results and then got better after protamine. Can you address that quickly? It kind of doesn't make a lot of sense, but I'm sure you're familiar with that paper more than the rest of us listening to it for the first time.
Of course. So what the authors argue is that MUF actually increases your concentration of heparin in the patient because you're taking off all that crystalloid volume and concentrating down the blood. And as we know, the ultrafilter doesn't take off all the heparin. So his argument is that the heparin that's left during that 10 or 15 minutes of MUF is actually causing more and more bleeding that's not reversed until you're able to give protamine. So his argument is that if you don't do MUF and you give protamine right away, you won't have that excessive bleeding.
I don't believe that necessarily, because the TEG that's being done pre-MUF is done with a heparinase cartridge. So they're removing the heparin, but definitely food for thought and something to consider.
Definitely, thank you.
The way the TEG operates, it removes the heparin, but good thought. Well, listen, I want to apologize first to all the individuals who asked wonderful questions and comments. If you got a chance, look at the Q&A session. A lot of very, very knowledgeable individuals in this field have made some very, very good comments and recommendations. So I apologize for not getting to them. But before we conclude, and I thank all of our participants today, our next webinar is going to be August 17th. It's going to be one given by two attorneys very much involved in healthcare law. It should be, should healthcare providers be arrested for accidents? And that's coming on obviously the case that occurred in Nashville over the last couple of years. So please participate with that. And with that, I want to thank both Chelsea and Alex. Wonderful job. It's amazing you both work together, and I don't want to see your performance report next, Alex, since you had to debate your boss. But knowing Chelsea, I'm only kidding, of course. Ed, it's great to have you on board and moderating this section, and we look forward to more participation with you as well. The emails are up right now. Chelsea and Alex, please feel free to reach out to them independently off of this particular venue. And if you have any issues associated with any aspect of the logistical, getting your CU certificate or making sure you got it, you can reach out to Ed or myself. Our emails are here, and we'll make sure that we handle that for you promptly. So with that, I thank everybody. I thank everybody for attending this webinar. I thank our presenters and our co-moderator. So I hope you all have a wonderful evening.